Hello everyone, welcome to Study MEDIC platform for RRR YouTube series. Today I am going to discuss three important topics here. One is the monochoronic twin pregnancy, female genital mutilation and fetal growth restriction. So quote of the day is a little progress each day adds up to a big results. What does it mean? The MRCOG Part 2 examination is not a sprint running, it's a marathon. So each day you try to input something from the topics and gather all the information because that will end up. I have never seen anyone to fail in this examination who has given preparation time for at least 3 to 6 months. So giving this much amount of time and gathering little information each day is a very important part. So coming to our first topic is the management of the monochorionic twin pregnancies. Now, as we know, the first after the fertilization, the first within the 24 hours pronucleus forms. That is a sign of fertilization or zygote formation. From this zygote formation, if the twinning begins within the 3 days, it is usually the dichorionic diamniotic DCDA twinning pregnancies. Whenever this twinning happens after the 3 days, there's a high chance of getting monochorionic twinning pregnancies, and whenever this happens after 8th day, there is a high chorionic having monochorionic monoamniotic pregnancies. As per the guideline, almost 20% of the twinning pregnancies in UK are monochorionic twin pregnancies, and only around 1% of the monochorionic pregnancies are monochorionic monoamniotic pregnancies. The increases is the prevalence of the monochorionic pregnancy largely due to the IVF procedures are gradually increasing in the last 2 decades. Now, the few important part regarding the antenatal care is to have to remember here. One is the important thing in antenatal care is to decide the chorionicity. And the best time to do is offering the ultrasound examination in between 11 to 14 weeks of gestation. After 14 weeks of gestation, it's become difficult to know the exact chorionicity. So best time to perform the examination for chorionicity is 14th weeks of gestation. This is your SPA. After this gestation, fetal sex determination may help sometimes to allocate the chorionicity. And whenever you're deciding for chorionicity, you need to adjust a CRL crown drum length in between of 45 to 84 mm. And if some woman has missed this period of gestation for determination of chorionicity, you can use a screening for quadruple test for the quadruple test for the first trimester combined screening if they have missed. Now, how often you need to do ultrasound monitoring for this kind of pregnancies? Please remember, from the 16 weeks onwards, every 2 weeks you need to do an ultrasound examination, especially to note on the Doppler and the amniotic fluid level from these weeks. Because after the 16 weeks of pregnancy, the chances of complications like twin-twin transfusion syndrome or selective fetal growth restriction starts to begin. So first scan after 11 to 14 weeks, then from the 16 weeks onward, each of the after 2 weeks interval you need to do continuous serial interval monitoring. Now, why these complications happen in these monochorionic pregnancies? All monochorionic placentas has a vascular anastomosis running between two fetal umbilical cords. This can be either artery to arterial, venous to venous, or artery to venous anastomosis in the chorionic plate. The most common complications begins when there is an unequal or ubiquital transfusion begins from the artery to vein in the chorionic plate. In the twin-twin transfusion syndrome happens when there is an unidirectional artery-venous anastomosis happen where a large portion of the placenta supplying a particular twin, that is a recipient twin, which becomes larger in size. And whereas TAPS twin anemia polycythemia sequence happens when in the small artery venous anastomosis, that is a minuscule artery venous anastomosis, those are the less than 1 mm diameter, allowing relatively slow transfusion of blood from the donor to recipients. Selective fetal growth restriction happens when there are arteriovenous ubiquitous placental anastomosis into the conjoining fetal circulations. You can see here in the twin-twin transfusion syndrome, these are the large arteries in the above in the chorionic plate. There is circulation begins and supplying in the one of the donor particularly. So in these cases, usually the as large arteriovenous anastomosis happen, the fluid balance disbalance is the first manifestation happens, and the recipient often become polyhydramnios hypervolumic also, whereas the donor become hypovolemic. Whereas in cases of twin anemia polycythemia sequence, it happens in between the minusculate arteries. Only the blood portion has been differentiated. That is, the anemia happens in the donor and the recipient has polycythemia. Here there isn't much difference in the volume, and the oligo and the olipoly is not present in cases of TAPS. Coming to the twin-twin transfusion syndrome, approximately 15 to 20% of the monochoronic twins are complicated by twin-twin transfusion syndrome. Here, due to unequal sharing of the placenta from presence of an arteriovenous anastomosis from the donor twin to recipient twin blood circulation happens, and the donor twins become anemic, hypotensive, oliguric, oligohydramnic. Growth restriction and renal failure can occur. If not treated, fetal demise can also occur, whereas recipient twin become polycythemic, hypertensive, also polyuric, polyhydramnionic, and these recipient twin are increased risk of having heart failure and hydrohospitalitis, and this they may also have consequence of fetal demise if not untreated. Now, how do we assess this twin-twin transfusion syndrome? One of the common staging method is a Quintero staging method developed in 1999. It has a 5 stage. First stage is where the oligohydramnios and polyhydramnios you have to look at the fluid level, and here also there is a discrepancy in the fluid level. Donor bladder is still visible because it has a few urine left, whereas in cases of the stage 2 you can see that the donor bladder is not visible here. Okay, and the stage 3 is where the Doppler abnormality starts to begin. There may be absent or reverse end-diastolic blood flow, reverse ductus venous blood flow, or pulsatile umbilical venous flow. Stage 4 is a more severe form where hydrops has been generated in the recipient twin. And stage 5 is that one or single fetal may have died due to consequence of twin-to-twin transfusion syndrome. Outcome depends on the staging and at the what stage treatment has begun. In the stage 1, usually 91% survive, whereas in stage 2 it's around 88%. See how drastically decreases the prognosis in the stage 3 and stage 4. How do we screen for twin-to-twin transfusion syndrome? Screening should begin at the earliest as possible. Ideally, should screening begins from the 13 weeks when the first trimester screening happens, but usually we recommend because it is very difficult to identify this at this period. So usually recommended screening period starting period is around 16 weeks onward, and after 16 weeks, each after 2-week interval, you will need to do a biometric scanning. If there are concerns about the difference between the amniotic fluid levels, as we can see the second trimester, whenever you find discrepancies of the volume of more than 4 centimeter or more, then you need to think of twin to twin transfusion syndrome in cases of monochorionic twin pregnancies. What are the treatment methods we can offer in this way? If the twin-to-twin pregnancies has been diagnosed before 26 weeks, it should be treated via fetoscopic laser ablation rather than using amnioreduction or septostomy. After 26 weeks, it needs to be individualized. Whenever using a fetoscopic laser technique, you need to use Solomon technique. Solomon technique is where all the anastomoses are laser ablated from the equatorial region. This is the equatorial region, and where from this whole of the equatorial region all the capillaries are to be laserly ablated. After this treatment, you need to monitor these patients also carefully. Weekly detailed ultrasound examination, especially examination of the fetal heart, is recommended. Coming to the next complication, that is a twin anemia polycythemia sequence. Approximately 2% of monochoronic diamniotic pregnancies are suffered by this, but after the fetoscopic laser ablation in twin-to-twin transfusion syndrome, around 13% of pregnancy may have complicated due to the procedural or iatrogenic twin anemia polycythemia sequence. How do you identify twin anemia polycythemia sequence? These are the major large arteriovenous anastomosis and these are the minusculate arteriovenous anastomosis. Here, the only as the connections happens in between this minusculate arteriovenous unidirectional supply. So here there is, although there is not much difference in the volumes happen, there won't be any discrepancies in the amniotic fluid volume. So usually they have normal amniotic fluid measurement, although they have a Doppler abnormalities. Fetal anemia in the donor and polycythemia will be seen in the recipient. How do you identify that? There should be a difference in the middle cerebral artery peak systolic symmetry greater than 1 mm. MOM. Usually anemia is defined when it is greater than more than 1 and polycythemia defined as when it is a less than 1. When this difference is more than 1, you need to think of doing anemia polycythemia sequence. And if you not diagnosed antenatally, can you diagnose postnatally? If the postnatally there is a highly discordant hemoglobin level between the fetuses with measured reticulocyte count more than 1.7, then it had been diagnosed with twin anemia polycythemia sequence. Now you can see here in the Doppler, they are in this recipient twin. It has been the around twin donor twin. There has been anemia and the blood flow is around mean systolic MCVA is more than 1.66, and whereas recipient has anemic velocity and the median of difference is more around 1 mm, so it has been diagnosed. So whenever it is a less than 1, it has been polycythemia. It is in more than 1.5 mm, it has been diagnosed with anemia. And two things you need to do in EMQ to solve: first look at there is a fluid volume presence or not, and if it is there is a discordant MCA-PSV is present along with normal fluid and normal bladder, think of the twin anemia polycythemia sequence. How to differentiate from the twin-twin transfusion syndrome? In twin-twin transfusion syndrome, fluid amniotic fluid volume won't be a normal. There will be always will be an Oli and Poly syndrome presence along with Doppler difference. Now, there has been staging system for the tabs also. One is staging system for antenatally, another is for postnatally. Both are based on the difference in the MCA-VSP Doppler velocimetry test. How much it depends on the sequence of the how much compromise of the cardiac compromise has been happening to the donor twin. Accordingly, that the staging has been created. And in postnatal period, according to the hemoglobin difference or reticulocyte difference, the staging has been created. How do you manage twin anemia polycythemia sequence? Usually, this condition should be screened using serial Doppler assessment in all monochoronic twin pregnancies. Special attention should have been paid from 20 weeks onwards. Usually, it has to be treated with similar fetoscopic laser surgery is the only therapy regarding the ablation of the minusculate anastomosis as much as possible. Fetoscopic laser ablation for the treatment of twin-to-twin syndrome, like similar Solomon technique, should be used because it has shown that the using Solomon technique significantly reduces the risk of recurrent diseases and TAPS. Selective growth restriction. Selective growth restriction is where estimated fetal weight is less than third centile or there has been any of the three of these following. There will be a discrepancies of the estimated fetal weight more than 25% or the smaller fetus is having EFW or AC is less than 10th centile. Abnormal umbilical artery Doppler of of the smaller fetus should be present. This complication can be seen up to 20% of the monochorionic twin pregnancies with selective fetal growth restriction. Now, how do you screen for this? Screening should be begin from the 16 weeks of gestation, and you should use this formula: larger twins weight divided minus the smaller twin weights divided by the larger twins weight into 100. If it is more, the discrepancy is more than 25% or more than 20%, you need to think of the SGR. There are three types of SGR happens here: type 1, type 2 and type 3. Type 1 is where the growth discordance is present but there is positive diastolic velocities in the both fetal umbilical artery. And stage 2 is where there is absent or reversed end diastolic velocimetry is present. Stage 3 is where there is a growth discordance with the cyclical or umbilical artery diastolic waveform is present. Now, how to differentiate from this selective fetal growth restriction from twin-to-twin transfusion syndrome? One of the key important thing of the diagnosis of twin-to-twin transfusion syndrome is there will be a poly will be present, but not necessarily in a fetal growth restriction there needs to be poly present. Here always the growth discrepancies will be given in your question and the growth discrepancies will be more than 25% or one of the twins will having EFW less than 10th percentile. So these are the few points you need to care to distinguish between the selective fetal growth restriction and twin-to-twin transfusion syndrome. So often you guys will be having an EMQ where you guys will be giving us such a scenario of multiple things and you need to identify which one is twin-twin transfusion syndrome, which one is twin anemia polycythemia sequence and which one is selective growth restriction. Now, treatment depends upon when the growth restriction starts to begin. Always SGR patients should be referred to the fetal medicine specialist center. In cases of the early onset selective fetal growth restriction, there should be selective reduction or fetoscopic laser ablation should be done. SGR fetuses always need an interval of surveillance of every 2 weeks. Doppler assessment should be done in these patients. For type 1 SGR has been diagnosed, the delivery should be done in between of 34 to 35 plus 6 weeks of gestation. Coming to last complication, that is a trap, twin anemia, twin reversed arterial perfusion syndrome. Why this happens? You can see the and mean that this cardiac twin lacks the well from heart and is to be perfused by this twin which has been well formed. This twin is called the which normal heart is called as a pump twin and this twin is called as a not well formed heart a cardiac twin. From this twin all the blood supplies are transfused to the cardiac twin. This occurs when a network of vessels connecting the twins through the placenta results in a pump twin heart supplying a blood to both twins. The cardiac twin often has a poorly developed body missing head, torso and limbs. As you can see in this diagram here, it is actual delivery of an trapped patient. Now coming to the delivery of the monochorionic twin pregnancies, as I have already discussed regarding selective fetal growth restrictions, see you need to carefully because in often they give you a scenario and ask if this is the selective fetal growth restriction, you need to identify the severity criteria of that. It is an early or if the discriminant is more than 35% or there is a ductus venosus PPI is more than 95 percentile. In those cases, you need to have an active management. You need to plan an individualized plan for the delivery. Now, another complication is an important complication of the monochorionic twin pregnancy where a single fetal twin demise has happened. Single twin demise can happen in via TTTS, SGR or TAPS. Here I will be discussing, already discussed the previous one. Here I will be discussing the twinning pregnancy where it has been complicated by single fetal demise, not due to the TTTS, SGR or TAPS. Please remember they have a higher chance of having death or neurological abnormality. Around 15% of death and neurological abnormality is around 26%. After a single fetal death in a monochorionic twin, the risk of demise of co-twin, also the prematurity, need to be considered. The aim of the birth of the fetus should be think of 36 plus 6 weeks of gestation. Please remember that don't do the MRI immediately. A conservative approach should be taken first, then a serial fetal brain ultrasound should be done, and fetal MRI scan should be planned after 4 weeks of the sentinel event. Because that is when you can identify the actual neurological damages are present or not. Now, how do you time an uncomplicated monochorionic twin pregnancies? They should be offered for birth plan around 36 completed weeks. In preterm birth, a monochorionic twin should be planned if up to 36 plus 6 weeks of gestation. If before 34 weeks maternal 5 weeks, then you should provide a corticosteroid as well as magnesium sulfate. Now I am coming to one of there are two types of MCQs comes from the monochorionic pregnancies. One is from where you guys will be given a scenario and you need to identify what type of complications. Another types of EMQ come is that where they give you a scenario, you need to identify when to do a delivery and what the mode of the delivery should be. As we know, for dichorionic diamniotic pregnancies, you need to deliver around 37 to 38 weeks of gestation. For monochorionic diamniotic, you can do a delivery around 36 to 37 weeks. Whereas monochorionic monoamniotic, you need to consider delivery at 32 to 33 weeks because there is a high chance of cord entanglement and the delivery should be always by the cesarean section. For triplet pregnancies, delivery should be considered by 35 to 35 plus 6 weeks of gestation. Triplets with shared placenta need to be individualized delivery plan. For monochronic twin with twin-twin transfusion syndrome, consider delivery by 34 to 36 weeks of gestation. If it is a complicated twin-twin transfusion syndrome, you need to individualize. For selective growth restriction type 1, you can do a delivery for 34 to 36 weeks. For type 2 and type 3, around 32 weeks. If the severity scores are high, you may consider delivery before 30 weeks also. Now coming to our next topic is the female genital mutilation and its management. There are four types of female genital mutilation happens. Type 1, type 2, type 3 and type 4. Type 1 is where the partial or total removal of the clitoral is be there. There will be total or clitoral removal partial removal of the clitoral hood. This is the most common type. And type 2 is where there is a partial or total removal of the clitoris and the labia minora. This portion will be also removed, but the labia majora may or may not be also removed. Type 3 is the most dangerous one, which has a higher rate of the obstetric complication, is where there has been making a covering seal in order to narrow the vaginal opening. This is known as an infibulation. There is a partial or total removal of the clitoris and the inner and the outer labial lips, and the outer lips are thousand and sealed with so that the leaving a small narrow area. They may also have a urinary difficulties also. FGM type 4 is a very milder form because it is where where the piercing, cutting, burning, scraping, picking, these are happened. So this is a very milder form of mutilation. What type of complications can happen in due to the FGM? Some short-term complications like hemorrhage, genital urinary retention, genital swelling, severe pain, poor wound healing. That's a common complication. Please remember, after the mutilation, urinary retention is around 8 to 53%. Long-term complications are genital scarring, lower urinary tract symptoms, dyspareunia, dysmenorrhea, chronic infection, impaired sexual function, sometimes psychological problem also. What are the obstetric complications? There has been increased incidence of having a stillbirth and neonatal death. Now, this is a very important, everyone should know about the FGM and the UK law. It is a very important thing. Please remember that FGM is illegal in everywhere, and it's unless it has been done due to the surgical purpose or medical purpose for on a girl or woman irrespective of her age, which is necessary for her physical or mental health, and she is any stage of the labor has just been given birth for the purpose connected with the labor or birth. It is illegal to arrange or assist in arranging for a UK national or UK resident to be taken overseas for the purpose of FGM. It is an offence for those with the parental responsibility to fail to protect a girl from the risk of FGM. If FGM is confirmed in a girl under 38 years of age, then if FGM has been confirmed, girl under 18 years of age, reporting to the police is mandatory. Often in your examination, if you need to note the question what the age of the patient is, where if the victim is less than 18 years old, first thing you need to do the report to the police is a mandatory, which is a mandatory, and it must be done within the 1 month of confirmation. These are some legal responsibilities for gynecologists that has to be maintained. Data recording is a pre-mandatory data recording for all women, and data recording should be done anonymously. And document of FGM diagnosis should be given in the medical record, and type of the mutilation has to be recorded also. Reporting to police and a social service in the event of the risk should be done, especially if the children is under 18 years. Now, sometimes they may have a question where after recent FGM, what you need to do. All healthcare should know that after recent FGM may have some complications or that include pain, hemorrhage, infection, and urinary retention. Some, if it is a FGM, is a type 4, usually it doesn't require any further treatment. Now, for the management, if you can have a EMQ or SPA, you need to first thing you need to ensure is that the all children with the FGM or suspected FGM should have been seen within the child safeguarding service. Clinicians should be aware that the psychological sequelae and the impaired sexual function can occur with all types of FGM. All women should be offered the referral for a psychological assessment and treatment, testing for HIV, hepatitis B, and hepatitis C, and sexual health screening. Where appropriate, women should be referred to a gynecologist, a subspecialist, and psychosexual services, and urogynecology and infertility clinics as well. Remember, de-infibulation may be required prior to any gynecological procedure like surgical management of miscarriage or termination of pregnancy. De-infibulation. What is de-infibulation? It is a reverse of infibulation. When infibulation has been affirmed, to overcome it, you are doing a de-infibulation. Infibulation is a type 3 mutilation where how do? You first infiltrate the scar with a local anesthetic agent and excise the scar, and then suture with then the cut edges you need to overseam with a fine absorbable suture, especially with 2,0 follicle actin suture or suture you need to overseam it so that it can maintain a normal opening of the introitus. Please remember that the one de-infibulation has occurred, you cannot undo it even on the patient's request. Now, how do you manage in a FGM in a pregnancy? First, three things you need to do whenever a woman in a pregnancy comes with an FGM. You need to ensure that you have consultant has known, and you need to ensure that the child safeguarding risk assessment has been done. You need to do a risk assessment tool for the assessment. Data recording should be have comply with the HSCIC, and also then you have to ensure the clinical management plan. So coming in women with the FGM, you not only managing them, you need to do a data recording, also a safeguarding planning, which are the first and most important thing before doing a clinical management. Now, if woman comes in the antenatal period, you need to offer them for a psychological assessment, and also need to screen for the hepatitis and any other infectious disease. Also, you need to assess their obstetric risk factor, their vaginal opening, whether they have a higher risk of having an intrapartum complications or not. What you need to do intrapartum period is that you need to counsel that they have higher risk of having a cesarean section, perineal trauma, and hemorrhage. It is suitable to deliver that women in a consulted lead care unit ideally should be delivered, but sometimes in a midwifery lead care can be delivered also if they have a history of previous uncomplicated vaginal delivery. Only then, if they require de-infibulation, sometimes may also be required. For postpartum period, you need to document the maternal history of FGM in person in personal child health record. Then that is a red book. If the delivery of a baby girl has happened, you need to notify a safeguarding midwife who should inform the GP and health visitor. Coming to our third topic, that is management and investigations of a small for gestational age fetuses or FGR growth restricted fetuses. You need to identify the terminologies properly. What is the appropriate age for gestational age, where the fetal size has been maintained in between the 10th and 19th percentile? How do you know the fetal size? In each and single ultrasound or biometric measurement, you need to measure head circumference, abdominal circumference, female length, and also the biparatal diameter, and should use a Hadlock formula to calculate the estimated fetal weight. If the estimated fetal weight is in between 9th, 10th to 19th centile, appropriate gestational age has been considered. Who are the small for gestational age? If the fetal size is less than 10th centile, it has been considered as a small for gestational age. Now, what is the fetal growth restricted? Fetal growth restricted are those who have a fetal size or abdominal circumference less than third centile, or they have a fetal size or abdominal circumference less than 10th centile with and Doppler abnormality. They are fetal growth restricted. If it is before the 32 weeks, it is be considered as an early FGR. If it is after 32 weeks, it would be considered as a late onset FGR. Now, there is another two terminology you need to be aware of. One is a static growth and one is a suboptimal growth. Static growth is where there's been no growth velocity is observed on a two serial scanning where EFW and AC has been measured in a 14 days apart. And what is a suboptimal growth? That when it has been diagnosed when the previously when AC and EFW crossing the centiles greater than 2 quartiles on non-customized growth centile chart in more than 32 weeks, it will be considered as a suboptimal growth. And in cases of those multigravida women, if they have a previously well-grown fetus which fails to maintain the adequate fetal growth during the pregnancy, it would be considered as a suboptimal growth. Now, coming to the two types of suboptimal fetal growth restriction, one is early onset, another is a late onset. Early onset are those who have a more than less than 32 weeks of gestation. If the AC or EFW is less than 3 centile, or there is a umbilical artery Doppler abnormality. What kind of Doppler abnormality is present can happen? One is a uterine artery Doppler abnormality, is that PI is more than the 95th centile, or umbilical artery Doppler abnormality where the PI is more than 95th centile. Early FGR also often coexist with maternal manifestation and placental dysfunction like hypertensive disorder, preeclampsia, or maternal medical condition, and thus easier to detect through the screening pathways. Late FGR happens after 32 weeks, and it is where the AC and EFW is less than third centile, and one of the two, these two among the three should be present. One is the AC and EFW less than 10th centile, or AC EFW crossing the centile with more than 2 quartile of on growth centile. This is what is known as a suboptimal growth, or the CPR is less than the fifth centile, or uterine artery, umbilical artery PI is more than 95th centile. The late onset FGR, the deficit in the placentation is milder with a less cardiovascular adaptation and a lower risk of adverse event. However, late FGR is a more common and it is more difficult to identify. FGR in a previous pregnancy versus current pregnancy. FGR has a two type of definition. One if they have a previous pregnancy, one in the current pregnancy. Now coming to the FGR in a previous pregnancy, if the birth weight is below the third centile in a previous pregnancy, or the earlier as a history of early onset preeclampsia or FGR necessitating birth before the 34 weeks in a previous pregnancy, or the birth weight below the 10th centile with the evidence of placental dysfunction, if all these are present in a previous pregnancy, you need to consider for a FGR. Now coming to the current pregnancy, if the EFW or AC is below the third centile, or EFW or AC below 10th centile along with Doppler abnormalities, then the current pregnancy you can say it is an FGR. Now, what you need to ask in the booking history, all pregnant women, the risk of FGR should be carried out by 14 weeks of gestation using an agreed care pathway or the local care pathway. All so it is a very important, you should be screened, all the women should be screened for the FGR by 14 weeks. It is a similar to when you should determine the chorionicity also. Now, the birth weight, gestation, and the birth weight centile of all previous pregnancies should be recorded at the booking appointment. The proposed plan of assessment should be altered based on the specific combination of the risk factors, and this should inform further targeted tests, and such as uterine Doppler when is available, and or serial ultrasonic surveillance. What obstetric histories you need to take. Previous FGR or SG in a newborn, high recurrence risk if the prior placental dysfunction is there, requires increased surveillance in subsequent pregnancies. Previous stillbirth, higher risk in previous stillbirth is linked to the FGR or the placental issues also present. Previous preterm birth, especially if the preterm birth happens before 28th week. Previous pregnancy loss also has a higher risk, and placenta-mediated complications like preeclampsia, placental abruption. Such type of patient should be put on aspirin from the 12 weeks onwards. Some maternal condition also predisposes risk of having a FGR. Strong association are the diabetes, vascular disease, chronic hypertension, SLE, APLA are present. Now coming to the maternal demographic factor, also women overaged or the overweight or higher BMIs or thin weight patients with a obese, morbidly obese, had bariatric surgery, all are the higher risk. So here you need to divide and know all the risk factors, which are the moderate risk factor and which are the higher risk factors. You need to go through this. It has been given in the guideline in the appendix. Now, what are the biochemical markers should be used for the aneuploidy screening if that's a history of a FGR? How can you identify FGR using the biochemical markers? When there is a low PAPPA, pregnancy-associated plasma protein, and race alpha fetoprotein or race inhibin A are detected incidentally, you need to think or you need to rule out or screen for the FGR. Women with a low PAPPA or raised beta HCG level should be offered aspirin also. Please remember this. Whenever a woman you have found that there's a low PAPPA and rest alpha fetoprotein or rest inhibin A, you need to start think of the surveillance of the FGR, especially early onset FGR. How do a mid trimester anomaly scan in here? So you need to do an uterine artery Doppler should be carried out in between of 18 to 23 weeks or 18 to 24 weeks in these women if they have a history of a previous FGR, previous preeclampsia, previous stillbirth, or any maternal medical condition like or connective tissue disorders, or there is abnormal biomarker has been described. In these cases, you need to do an uterine Doppler care should be carried out. Clinical On the clinical examination, symphysis fundal height measurement should be done. Serial symphysis fundal height measurement should be done from after 24 weeks onwards. The first trimester, first measurement should be carried out by 28 weeks at least. Women with a single symphysis fundal height which plots below the 10th centile or serial measurement which demonstrate suboptimal fetal growth with no apparent fetal growth over the 2 weeks, that is a static growth, should be referred to ultrasonic measurement for the fetal size to screen for the exam for the fetal biometry and Doppler to screen for the FGR. Remember, obese women having a BMI more than 35 or woman has a history of fibroids, they where in these cases fundal height measurement is a suboptimal. Now coming to the uterine artery Doppler waveform, uterine artery Doppler waveform should be conducted ideally via the 18 to 24 weeks of gestation. In a high risk population, you need to do it by to identify early onset SGA. You should be doing by 20 to 24 weeks at least. Women at higher risk with a normal uterine artery Doppler in a mid trimester. Now you know the risk factors, you can identify which are the high risk, which are the lower risk. If the woman belongs to the higher risk, to uterine, if you have done the uterine artery Doppler and the normal fetal biometry has been shown, then the serial scanning should be done from the 32 weeks. And if you find that has been abnormal uterine artery Doppler, you should start the serial scanning from the 24 to 28 weeks. Now, this is a very important ultrasonic assessment of the biometry are very crucial to determine the FGR. Fetal size is not sufficient to diagnose FGR because many of the fetuses with growth below the 10th centile are healthy and they are only constitutionally small. They are not FGR. Fetal growth disorder should be suspected when there is a suboptimal reduced fetal growth velocimetry. FGR can be diagnosed when a drop of more than 5th centile in EFW or AC has been shown. It's a very important downward trend of a AC is the first thing is the key because it is the liver is the first thing where it start to begin compensating as so the abdominal circumference start to reduce first, and the brain is the last organ to affect because it is the most vital organ, so the fetus try to protect the vital organs like brain, heart rather than sacrificing the abdominal circumference liver. Doppler velocimetry or of the uteroplacental circulation may be assessed to use distinguish between the SG and FGR and must to be done. Now, few important things about the maternal history you need to know if they have to counsel they to reduce the smoking or the stop smoking because mostly more smoking has a very bad impact in the placental circulation. There has been multiple micronutrients has been advised, but RCG recommends that the all women should continue to take at least 10 microgram per day of vitamin D and 400 microgram per day of folic acid from preconception and for first 3 months of the pregnancy at least, because it has shown it may reduces the risk of the FGR. Women who are at risk of the preeclampsia or placental dysfunction should take aspirin 150 mg once daily at night from 12 to 36 weeks of gestation to pregnancy to reduce their chances of SGA and FGR. Remember, low molecular weight heparin and corticosteroid should not be used to prevent FGR. This is a very important chart, and all of you should be knowing this because two important chart in this topic you should be knowing, and you guys should revise this 2 days before going to the exam also. You guys should be knowing all the risk factors and specifically which are the moderate risk factor, which are the high risk factor. You need to identify these. If the moderate risk factors are present in the end during around the anomaly scan or around 18 to 20 weeks scan, what you need to do, you need to start commence serial growth scan from 32 weeks onwards. Okay, and if the high risk factors are present, you need to do an uterine artery Doppler scan here by at least by the 18 to 24 weeks. If the uterine artery Doppler scan showed it is a normal, then you need can commence the growth scan or serial fetal biometry from 32 weeks onwards. Okay, now if it is a normal uterine artery Doppler and but EFW or estimated fetal weight is less than 10 centile, then you need to start serial growth scan by 26 to 28th week. If it is an abnormal uterine artery Doppler with normal EFW more than 10 centile, then you need to commence by 28 weeks. And if there is an abnormal uterine artery Doppler and also EFW is less than 10 centile, you need to individualized care plan discussing with a fetal medicine specialist. So you need to aware at the which week. You guys will be given a scenario of individual thing like a normal uterine artery Doppler and less than EFW 10 centile, then you need to start 26 weeks. They will be asking you from which weeks you need to start screening. You guys should be aware of this chart very carefully. And often EMQs come from this chart. Now, few points regarding the management of FGR. Antenatal corticosteroid should be offered if the woman is in between the 24 to 34 plus 6 weeks of gestation. Ideally should be offered at least 48 hours prior to the anticipated birth. Magnesium sulfate for neuroprotection should be offered in between 24 to 29 plus 6 days of gestation and considered up to 33 plus 6 weeks. If FGR fetuses with abnormal CTG or STB, ductus venous alteration or umbilical artery absent or reversed in diastolic flow velocimetry is present, cesarean birth is recommended and should occur after administration of the steroid and magnesium sulfate. Now, if the SGA and the left FGR is been present, induction of labor can also be considered in those cases. For early FGR, it is a better to do a cesarean section delivery for those patients. For late FGR, you can do a induction of labor, but you need to know counsel that there is a higher risk of emergency cesarean section. And for induction of labor, you can do an mechanical dilatation also. This is a very important chart. Now you have know which type of onset of FGR is there. If it is an early FGR up to 32 weeks, then you are be doing measuring the estimated fetal weight fortnightly. You will be doing umbilical artery and Doppler weekly. You will be measuring the estimated fetal weight fortnightly and doing an umbilical artery Doppler a weekly. So if it is in between these weeks, you need to very carefully monitor whether there is an absent or reverse of endostolic flow in umbilical artery or not. Monitor minimum twice weekly with an computerized CTG for this patient. If that you need to deliver, consider for early onset FGR, you need to consider deliver by 32 weeks if there is an umbilical artery abnormality has been shown. If the DVA wave is absent and STV is less than 2.6 and or the DVA wave is absent and STV is short-term variation is less than 3, then you need to consider the delivery by 34 weeks also. Now, for the woman with between 32 to 36 weeks of gestation, you need to carefully note at the umbilical artery Doppler, where you will be do umbilical artery Doppler you will be doing weekly and measuring the EFW fortnightly. Here the delivery should be considered by 36 to 36 weeks of gestation. if only the umbilical artery PI has been maintained, has been more than 95th centile. If the woman is having a FGR or diagnosed is around 37 or 38 weeks or more than 30 weeks, you can manage it as a normally like in that fashion. So here are the three major topics has been discussed. One with the monochronic twin pregnancies, where you guys can have a two types of EMQs. One is how to diagnose and how to differentiate between all types of the complications from monochronic pregnancies and when to plan a delivery. And from FGR you can have a two type of EMQs. One is the when what weeks and what type of monitoring should be considered depending upon their ultrasonography finding and depending on their Doppler status. You need to stratify according to the risk status. You need to stratify which are the high risk and which are the moderate risk also, and when to conduct delivery. These are the all important EMQs point. From FGR, often you guys fetal genital mutilation, you guys often have an SPA questions, and you need to know about the infibulation in details also. So thank you very much. Hope you guys have enjoyed this session of a small mini series or YouTube series here, and thank you so much.